Good afternoon, everybody. Thank you for joining us today for Inspire's monthly panel discussion. Today's discussion will focus on decisions in air medical transport, recognizing and managing the difficult airway. We will probably get around to segueing some of these difficult airway issues that are not just specific to transport. But today I have with me two good friends, colleagues, and experts in this area. John, could you introduce yourself?
Yes, John Inkrop, respiratory therapist, adult critical care specialist with the Advent Health Flight One program, Orlando, Florida.
And Joe?
Yay, John. Joe Hilton, respiratory therapist, ACCS, NPS, and National Registry paramedic, Atrium Health in Charlotte, North Carolina, and with Hamilton Medical.
Yeah, my name is Keith Lamb, respiratory therapist at University of Virginia on the Trauma, Surgical, and Neurosurgical Service. So welcome again. Appreciate everybody showing up for today's discussion. Essentially, we're going to talk about, we're going to do a quick introduction, what defines a difficult airway, anatomically difficult, physiologically difficult, which may be situational, physiologically difficult in terms of hypotension, etc. Assessment and mitigation, airway timeout, airway checklist, DAI versus DSI, video laryngoscopy versus direct laryngoscopy, and discussion. So I'm going to let these two gentlemen take over. If you have questions or comments, please put them in the chat section, like some of you have already done, and we'll try to address them in a timely manner.
So before I turn this over to Joe to kind of go through some of the things and some of the slides that he's included here, the three things that we want to talk about today, the anatomically difficult, the psychologically difficult, and the physiologically difficult airway, because they all carry with them different risks and risk mitigation, and how you go about identifying those airways and how you're going to treat those patients to inevitably not have any sort of peri-intubation problems when it comes to these airways. So we will go through those three, the anatomically, psychologically, and physiologically, how to mitigate any sort of risk or any issues and problems that you might have. I think you'll hear Joe and I probably say assessment many times, because assess is all you can do with these patients to make sure that that you're doing the right thing and that you don't get caught up or get behind the eight ball with some of these patients and then you're coding them. Airway timeout, airway checklist, those are so important. We do timeouts for all other sort of procedures. It just tends to fall by the wayside sometimes, especially in emergent situations where you're putting airways in that you don't do these timeouts, and then maybe you don't have the correct equipment, or you have a very, very rapid sort of intubation where your suction is not set up and you don't have the proper tools that you need. And oh, by the way, your laryngoscope handle, the batteries are dead in there. So there's a lot of things that you should be able to do to make sure that you mitigate any risk for having your patient code on you. Drug-assisted intubation versus the delayed sequence intubation. We are trying to get away from the rapid sequence intubation, because it tends to carry with it the misnomer that things need to be done fast, when we know that it's a rapid acting induction, but sometimes we need to kind of slow things down a little bit and kind of take the rapid out of that. And drug-assisted intubation tends to be better verbiage when you're identifying that. Video versus direct visual laryngoscopy. There is a good study that's out from 2023. We'll talk about that and then kind of wrap it up with discussion. So, Joe, I'll turn it over to you, sir.
Sweet. Thanks for leading into that. In addition to assessing, and it kind of plays into things, you've kind of pointed to it already. If you're managing airways, and it's an all-encompassing thing to you, you are a risk mitigator, because when we make the decision to take someone's airway, that's probably the one thing that we do that can kill a patient faster than anything else, and it's not something we take lightly. So when we get to that decision, there's a lot of things that should have taken place long before we started innovating. And then once we start doing the procedures themselves to line up with that. And again, just for full disclosure, all the photos and nice pictures you're going to see from a textbook standpoint, I did get permission from the folks at the Difficult Airway course, the Airway site, to utilize those. And they also come from their emergency management textbook from Walters Kluwer. You can swap slides, Keith. Go forward. First thing we want to talk about when you're managing airways. John and I joke about this a lot. It's not just, oh, I put the tube in. It is again an all-encompassing thing. The training that you do, if you're part of an airway team in the hospital, you might be the first person to arrive, and you're the one that's going to be doing the quick assessment and maybe setting the stage for what happens throughout that procedure. There's some folks in pre-hospital that are on here as well. Those folks can tell you very, very wholeheartedly, when they arrive, they are the help. You look at the second box up here on the left, it says call for assistance. Well, if you're in pre-hospital, you are the assistance when you arrive. So there's a lot of impetus on you to have your T's crossed and your I's dotted with everything from training to equipment to that forward thinking when you get there. So you can kind of see from this main global airway algorithm, if you walk into the room, first part, assessing. Do you need help? Do you need to act quickly? If not, you've got time to plan. And from that planning, it may be a simple, straightforward drug-assisted intubation. There may be some assessment pieces that pop up that make you alter that approach totally, which we'll talk about more towards the end. But this global airway algorithm, we're going to break it down into several smaller ones too to help you with thinking. Next slide, Keith. So if you move away from the global one to more of the main emergency airway algorithm, you can see once you've identified the need, you're immediately assessing your patient condition. Is it a type of cardiac arrest or crash airway? Yes or no? If it's no, then we're going to move into the assessment piece again. Is there anything pointing to this being a difficult airway? If it is, we're going to move over into the difficult airway algorithm. If not, we'll move over into our more straightforward, streamlined, drug-assisted or rapid sequence intubation type pattern and move through that. But you can kind of see how the boxes are lining up, how it's wanting you to think now and also have your mind maybe 2-3 steps ahead. So if something bad does happen, we have equipment ready and resources ready to be able to move into the next stage very streamlined and not waste any time. Next slide, Keith. If you look at the cardiac arrest algorithm, notice the first thing, it's not intubation. It's wanting you to look at BVM or do some type of extraglottic or supraglottic airway. And if your ventilation is successful there, you've bought some time. Depending on what your patient condition is, you may elect to wait and do an intubation procedure. For example, if you have someone that's in horrible heart failure, intubation might be a bad thing for them. If you've got a supraglottic airway in, you're able to oxygenate and ventilate and not put so much pressure in the chest that you kill what cardiac output they have, we may wait until we get to the ICU and can maybe optimize hemodynamics better before we actually decide to place an airway in. And when we do intubate that patient, it's probably not going to be a full rapid sequence type thing. We'll probably do a drug-assisted and maybe a conscious sedation type thing where we don't even do paralytics at all and minimize your benzos and narcotics to have minimal impact on your hemodynamics as well. So again, kind of a good thing to point towards where your mind might be when you walk into the room, where it may end up. Go ahead, John.
Just to go back and talk about, you can't just say you got the tube and maybe not include in your procedure that it took 3 or 4 attempts to do it, that your patient's saturations dropped to 68%, that your patient braided down and you guys almost had to do CPR. And oh, by the way, they became really hypotensive, so we gave push dose pressors. When you arrive in the ER, that information probably should be relayed to the ER team, as opposed to just rolling up through the door and saying, we got the tube and it's a 7-0, it's at the 25, peace out, see ya. So that goes along with the psychology of the difficult airway, because that information should probably be relayed to your ER team that this was a very difficult intubation, or at least you struggled with the intubation. Ultimately, it was achieved. However, these are some of the things that happened. There's also a lot of literature out now that's supporting non-invasive respiratory support for your pre-oxygenation nitrogen washout of these patients prior to intubating them. Maybe not so much in the helicopter, but in the ER and in the ICUs, this is becoming very commonplace to use non-invasive respiratory support in the way of CPAP or BiPAP to help these patients. Because of the BiPAP machine, you can set a backup rate, you can set a pressure that can hopefully achieve a certain volume. There are certain things in certain patients' anatomy that will preclude you from doing that, like a very thick neck or a full facial beard or sweat and vomit and blood and all the good fun stuff that we can get into. So again, just some things we're going to start to talk about as we move through some of these algorithms and point out the differences in some of these difficult airways.
Next slide, Keith. Again, looking at the failed airway algorithm, just to add on to what John was talking about, you might walk into an event going on inside the hospital or outside of it, and your first assessment that you might make, you might completely skip the BVM, the laryngoscopy piece, the supraglottic piece, and realize, oh my God, this patient needs to have a surgical cryoc procedure done. It doesn't happen often, but it's, again, one of the examples of if you're structured in how you approach these, your mind's in the right place, your equipment bag is set up for all these. Sometimes these cases can go that haywire and that strange that quickly. John Alaf, one of our surgeons, was with us a couple of weeks ago at one of these little short courses we took, and he stood up and didn't even speak for the first couple of seconds. He reached his pocket and he pulled the scalpel out. Says, "I got one wherever I go," and we know what it meant. But it's a case of surgeons like to do surgery, so they're prepared if they need to do that. But you can notice how quickly this may move from failed airway straight to a surgical cryoc out of the gate. Thank God they don't happen quickly, but be prepared, both from an equipment standpoint and mentally, physically, that some things can go haywire that fast.
Yeah, and I have a case in here that kind of really is a pucker factor. And in full disclosure, at my program, we are an interfacility transport program. So, we're not out in the field pulling people out of ditches and doing those sorts of things. However, we do have a training piece for can't oxygenate, can't intubate. So we do have front of neck access and cryo capabilities. However, from the mitigation perspective, I try everything in my toolbox, including my small brain up here, in ways to figure out how to not have to do that to a patient. Because I think that without doing them so frequently, like any skill that's a high risk, low volume procedure, they carry a lot of repercussions if you don't do them correctly.
They do. And for anyone that's probably more so in the transport side, you'll probably practice that skill more frequently. But if you've done it for a while, if you've really had your hands on stuff, most folks will tell you you've probably done the muscle memory with doing that procedure that you could almost do it with your eyes closed. What makes everything so frantic and so crazy is you've realized that, oh my God, we have to cut somebody's neck. And that's usually where the urgency and the craziness comes into play. The procedure itself, if you've done it, it's really not that bad, provided you can find your landmarks. Now, if you can't, that's going to add some ugliness to it as well. But most anyone that's done it, they'll tell you that first couple of seconds of, oh my God, we have to do a surgical cryoc, is just the worst feeling in the world.
And I think when Joe and I were in Asheville and I brought this up, there is a book by Malcolm Gladwell, and it's called Outliers. And in this book, he talks about what it takes to become perfect at something, to become somebody who is very competent at something. And that's 10,000 hours. 10,000 hours is where you have finally reached expert status. When you talk about the Blue Angels and you talk about the Boston Philharmonic and you talk about athletes, Olympic athletes, those are the ones that train for one event. And that's what we need to be doing as medical professionals, certainly in the way of endotracheal intubation and in the way of front of neck access. That's just not something that you do once or twice a year and say you're perfect at it. So it's something that requires deliberate practice. And that's something that we all need to take, whether you're a paramedic or an advanced practitioner or a respiratory therapist. That's something that you need to take into consideration.
Completely agree.
Talking about not having 10,000 hours and expertise in something I can remember many years ago, I read a paper about retrograde intubation. And then the very next day I had to do it.
Yeah.
And I've probably done it 3 times in my 26 years of managing airways. Yeah, it's crazy. It was just a person that was getting a lot of radiation. It was in hospital. Person getting a lot of radiation therapy on their neck, and arrested and went in to intubate them, and they didn't have any. There was no identifiable laryngeal anatomy at all, and I just asked the resident putting the central line in if he could put one in the neck, put a line in the neck for me, and point the wire north. And slid the ET tube over the wire. And I think I did it twice after that. But yeah, it'd be nice to have 10,000 hours worth of experience before you have to do something for sure.
For sure.
You guys are you guys going to talk about there's sort of been, I don't know if I want to call it a paradigm shift, but certainly a more interest and more focus on resuscitation before intubation. And you touched on it a little bit. Are you going to talk more about that?
Okay, so we can, yes. I don't want to give too many secrets away because I am lecturing on that topic at the ARC Congress. So we can touch on it a little bit, but I would like to hopefully keep my audience coming to that lecture. As I talk about peri-intubation, arrest, and shock index and cardiovascular collapse.
Yeah, so I mean, if you could just touch on a little bit. I mean, if we want to talk about physiologically difficult intubations,
yes, we will cover
and how to make that maybe not be a problem.
Oh yeah, we'll definitely touch on it.
Okay, cool.
All right. Matter of fact, the next section is going to be a good lead into it. So you
Next slide.
Hit the next slide if you want. So, looking at more of these maybe not so common situations, if you look at everything as a whole, but if you manage airways, then they're probably more common than you realize. But optimizing unstable patients, we'll just quickly run through these. We're not going to spend a ton of time on them. But if you look at column 1 on the very far left, hypovolemic shock, or really any kind of shock in general, we need to identify what kind it is and maybe work towards treating it. Because if you've managed airways, if you've done drug-assisted intubations, the last thing we need to be doing to someone who is in shock or about to go into it is start throwing a lot of narcotics and benzos into them. And we don't often think about paralytics, but if you've got someone that's really living off of their catecholamine drive and we drop some paralytics in place and we take that drive away, we're going to have a code in front of us. Keith and I have seen these, and it is not a pretty theme because when it happens, you immediately know that we did it. So from a hypovolemic shot standpoint, if we know someone's there, that may be a situation where we slow down, really move towards, from an oxygenation piece, the most minimally invasive, non-rebreather, high flow O2, heated humidified. Use your BVM if you have to, but try to use low pressures, and then work more towards working on the piece of why that patient's hypotensive. And if it's hypovolemic shock, if there's no bleeding, or if the bleeding's been controlled, then we can start working on getting some blood volume in there with whatever you carry, whether it's whole blood or blood products. Non-trauma, you're probably going to put some in there to increase your systemic vascular resistance, provided your cardiac output's where it needs to be. And depending on how successful you are with that aspect of things and what your guidelines will allow you to do, when you move towards your airway management, you still may or may not drop paralytics in place. You may choose to do an awake intubation or just do a drug assisted from a sedation standpoint, and modify how you approach that airway to get it in place without fixing or making worse what you just did a lot of effort at fixing. Septic shock, again, kind of falls into the same thing. Usually with septic shock, it's more of a tone issue in the volume, but we'll certainly work on increasing systemic vascular resistance. Any type of heart failures or right ventricular failure, again, what we do outside the airway is going to be just as important as what we do within. So the most minimally invasive type thing, using non-rebreathers or high flow O2, BiPAP even, to minimize intrathoracic pressure in the chest, and then try to optimize whatever cardiac output they have. In the hospital, you may have more tools. Outside the hospital, from a heart failure standpoint, it's probably going to be Levo that we'll go to as an initial agent. Notice I didn't say dopamine. for someone that's in right heart failure and their blood pressure's low, yeah, dopamine will get their blood pressure up, but they've already got a ton of SVR in front of them, and when you increase that squeeze even more with the bad heart, it's just going to make it worse. Severe metabolic acidosis. Can't speak about that one enough. Anything you can do for these patients to not intubate them, you probably should, because the brain stem is going to have a way better guideline of what that patient needs to do from a ventilation standpoint than we do. And once we put an airway in place, we're usually paying catch up for a lot of folks that don't deal with it a lot. So if they have a good drive to breathe and a good depth to breathe and they can protect their airway, probably shouldn't be messing with those patients and try to go to that underlying cause and work on it to get it fixed. If something's there that you do have to intubate these patients, as best you can, try to estimate their minute volume, because you're going to have to match it on your ventilator. It's not going to be that 5 to 8 liters a minute. You might be anywhere from 15 to 20 to 25 liters a minute with minute volume. And some of that might not be conceivable to do depending on what type of machine you have.
And I think that's where it gets very tricky for people who aren't very familiar with that, because you will not be able to match the minute ventilation on your ventilator. And that's why if in fact you have to do an intubation on a metabolically acidotic patient, you're going to really have to focus on returning them to a spontaneous breathing. So you're going to need to keep them sedated to a point where they can still be able to drive the bus on the ventilator and match their minute ventilation. Because there's no, even if you threw lung protection out the window and you start giving these patients 1 liter of volume, which will make my heads explode, you still won't be able to match them appropriately on your machine. So being able to correct them without having to intubate them, as Joe said, is extremely important, because you'll never be able to match that. And again, I wanted to mention shock index, because that's a really good indicator of how sick your patient really is. And that is your heart rate in beats per minute divided by your systolic blood pressure in millimeters of mercury. And you want it less than 0.7. Anything greater than 0.7 tends to show you a much sicker patient. And that is the patient that when you go to intubate them and they have a shock index less than 0.7, or I'm sorry, greater than 0.7, you might be having to code that patient after you intubate them. So it's important to know that, so you can at least treat them pre-intubation with getting their blood pressure up, which tends to be the standard these days, is to get their blood pressure up into the 110s, even higher than that in the 120s, before you even begin to try and intubate these patients.
Completely agree. Other kind of special circumstances you may see appear, and you can probably go through and make a list a mile long, but some of the more common ones that we see, we've talked about instability from presentations clinically. John kind of alluded towards the trauma airway, looking at shock index, and that can apply to septic shock as well, if that's going on. I'm going to start this topic, and I'm going to let Keith and John kind of chime in, because they had it in their slides. If you work in any kind of emergency trauma, surgical, critical care, or pre-hospital, we all know how much attention the neurocritical patient has on it, and especially when those patients can't protect their airway, We're having to go in and manage that piece for them. There's a few special things that we have to do as airway managers to really optimize on the front side, because depending on what's going on, there's one of 3 events this patient may experience. Even if it happens at one time, can have really bad long-term effects downstream to the point of even causing death. So I'm going to let John and Keith pick this one up and roll.
So, John, let me just, if you don't mind, let me just reiterate 2 really, really big points that you guys made that I think that everybody needs to know are big. One of them is that if you have a patient and they're breathing 40 times a minute, they're in profound respiratory failure, they're super tachypneic, tachycardic, and they've had this, and because of that, they have this intrinsic catecholamine release, and then you do anything to make that go away, you're looking at a serious issue. We used to intubate people with midazolam quite frequently way back in the day, and that would immediately make somebody's blood pressure drop and reduce the catecholamine release when you took their work of breathing away. So that's a big deal. And if you're responsible for managing somebody's airway, then you need to be aware of that. And that's sort of where some of this resuscitate before intubate paradigm shift has come into play. And that is, you need to know what's wrong with the patient. And I implore you to know what's wrong with your patient, no matter what role you're playing with them in their care. But if you know somebody is hypovolemic, that's one thing. If you know somebody is, septic or in distributive shock, that's another thing. And you may treat those patients differently. But the airway is most certainly almost never more important than making sure that you don't cause somebody to cardiac arrest. So that's the one point that I wanted to make before we moved on.
From a neurocritical care standpoint, John, anything you want to add there?
No, not particularly. No.
Okay, all right.
I mean, I can touch on that a little bit since you brought it up. So a neurocritical care patient may have some properties or experience some issues that other patients might not have. And depending upon what, let's take a person that's got a traumatic brain injury, for example, that is very sensitive to extreme spikes in intracranial pressure. If you don't do something during your airway, if you need to intubate, hopefully that person, either John or Joe have intubated that person before they get to me. But if I had to intubate them in the hospital, then I would really need to be cognizant of the fact that they have a traumatic brain injury, that they're sensitive to intracranial hypertension, and then to take an approach with the airway management that would mitigate acute spikes in that intracranial pressure. Conversely, there are some patients that have cerebral vasospasm, for instance, that need higher blood pressure. They need higher blood pressure in order to prevent further spasm. In that case, then the reverse would be important. It'd be important to not allow their blood pressure to drop too much. And those are things that I can think of off the top of my head.
Yeah, big things with neurocritical care, especially on the pre-hospital side. The killer H's, you'll often hear them referred to, and a lot of that came from Arizona Department of Health. A few years ago, they started this big push towards pre-hospital treatment of TBI. The EPIC study out of 2019, there's a paper out there on it. But the 3 big things out of that paper that they demonstrated for all comers for TBI, their approach didn't have any effect on mortality. But if you looked at severe TBI, Uh, managing those patients, preventing hypotension, preventing hypoxia, preventing hyper and hypocarbia. Those patients, their risk of survival doubled on the severe TBI side. If those patients with severe TBI had to be intubated, receive positive pressure ventilation, minimizing or not having the hypotension, hypocarbia, hypoxia piece happen, those patients that they were successful in, it tripled their survival when they looked at mortality. So you'll often hear the killer H's hit on. That's what they're talking about for TBI. But you don't want to make them hypotensive, because if you're looking at brain perfusion, mean arterial pressure minus ICP is going to give you CPP. So that's what's going to keep your brain perfused. If the patient has a hypotensive event, their blood's not being perfused, their initial injury is going to turn into a larger secondary injury. Same with hypoxia, or even hyperoxia for that matter. And then the same for carbon dioxide as well. Too much and too little can also cause damage. That's really the big thing on the neurocritical side. Reactive airway disease, another one we see a fair amount of. Big thing there, probably gonna, if you're able in your protocols or guidelines, or really probably see ketamine used for your induction medication, simply because it has some beta-2 properties that may assist you. We kind of talked about cardiovascular emergencies with the patients that might be in or near extremis with their blood pressure, or even if they have a bad pump. I don't think we probably need to go over the highly infectious patient after the last 3 or 4 years. Everyone's probably an expert at that, from doing it 2 and 3 times a day for 2 or 3 years. A couple of big things. We touched on it kind of talking pre-class. Someone that's had an emesis event before you get there, and their airway is just massively soiled. And we're going to have to do some airway decontamination before we put a tube in. Direct laryngoscopy is going to be nice. Video can be helpful there. There's some newer suction devices out now that have larger channels, the Ducanto type, that have larger openings, will let you be able to rapidly decontaminate that airway and maybe get a better view, and you might minimize how severe their infection may be when that happens. Probably the biggest one that scares all 3 panelists here, Keith and John alike, the pregnant patient or the obese patient. Because as soon as you lay eyes on them, you automatically know that there's just landmines laying all around, with maybe having to place an airway in that patient and having to move forward with it. So your patient positioning, if you're inside the hospital, is going to play into it. Your drug approach will play into it. You might not even do a direct or video type laryngoscopy. You may have an intubating stylet or a bronchoscope and place that airway. So you can not give any meds at all. The pre-oxygenation phase in those patients are going to be huge. Abdomens are going to be big, so their FRC is going to be a lot lower. If it's somebody that's just obese and their BMI is 45, 50 plus, then it's not just the belly weight, it's their chest weight too. That's going to allow you to give enough tidal volume to oxygenate and ventilate the way you'd like to. So those 2 patient populations, unfortunately, we're seeing more of them. But depending on where you are, John can probably chime in on this as well. There's probably been a couple that he's picked up that might meet every checkbox to place an airway, but we didn't touch it. We supported oxidation, supported ventilation, and either threw the jet fuel, the diesel fuel in it, and got down the road where we needed to be. Because
yes, that's
something's better than nothing.
Yeah. A good segue into the case that I had included in here. I don't know how many slides forward it is, but we can kind of show those pictures, and I can share with the audience.
You can jump ahead, Keith. It's fine.
So just identifying difficult airways there. We can go back into that. So this is the patient. Can you go ahead one more, Keith? Yeah, you can go back. Okay, so on this x-ray, we got called for this patient who had a massive laryngeal tumor with invaded the trachea. So there were some unknowns there. Like, us as the team had no idea what this tumor looked like in the trachea. We just knew that the patient had been intubated by anesthesia, who they called in the middle of the night. This patient was being transferred to one of our larger hospitals to undergo tracheostomy placement and you have some other things done with this tumor. So we get to bedside and we see that this tube is at the 17 centimeter line, and it is a 6O tube. And the critical care fellow there didn't want to touch the patient in the way of scoping them, NP scoping them, to see where the endotracheal tube was. Because when I looked at this x-ray, and you guys can look here too, I want you to look up there in the, I guess that would be the superior part of the neck. You can see a massive bubble there. That is the cuff on the endotracheal tube. And it is literally at 60 centimeters of water to seal it off, because it's a 6O tube. And it is sitting right at the vocal cords. So clearly this patient is somebody that you need to be extremely careful when you move them, if you even move them. So we had called for different resources. Can anesthesia come up and scope this person so we can see where this is? Maybe advance the tube a little bit under the use of a bronchoscope, that we could see where this was and where it was going. Nobody wanted to help us. So, we thought about different ways that we could do this, but at the end of the day, the patient, when we found them, they were paralyzed, which we would have done anyway, because we didn't want this individual to move. So we can go to the next slide. When we got to the hospital, over there on the left, that's the endotracheal tube, and that is the cuff sticking out of the vocal cords there on the left-hand side. So it's exactly what we thought it was. Our spidey senses were correct. We were very, very reluctant to move this individual, but ultimately, the individual had to get to the hospital to get some things done. So we had to do this, and we did it very carefully. But just goes to show you that, we had everybody and their brother say the tube's in the right place, the tube's in the right place. Well, the tube is barely in the right place. And of course, when we got to the receiving hospital, ear, nose, and throat was there. They did scope the patient, which gave us these pictures. And then the ENT was up there trying to digitally advance this tube. And guess what happens? The tube comes out. So better there that it happened under their auspices as opposed to mine in the back of a helicopter. But they got the individual intubated probably within 2 minutes. No CPR had to be done or anything like that. The individual actually had some good reserve because her SATs never dropped below 90. So they got another tube in her. But again, some very, very Tucker type moments that you will face probably in the ICU. That's why these things taken care of with ultra tender love and care. And I think there might be one more slide that shows. Yeah. So there again, on the bottom left, that is the cuff just ready at any second to pop out. And then you have no airway. And she did have the only amenable tissue that she had for a crike or front of neck access was 3 centimeters distal to the cricoid cartilage, which you couldn't see. So you would have to go 3 centimeters down. So basically you're doing almost like a perk trach. So again, this is not something that we're experts at, nor is it something that we wanted to do. So we took as much time as we needed, but the transport was successful. So
I know what ENT said, and I know what the referring hospital said to you. ENT looked at that and said, "Oh my."
yeah. Yeah.
And the referring hospital said, "Oh, thank God you're here," and they all disappeared. Yeah.
You want me to go back to where we were?
The decision to intubate slide will be good. That'll be pretty close to where we were. Bingo. So kind of moving away from the algorithm piece to, making the decision to have to take someone's airway, you can literally ask yourself these 3 questions and have that answer. You can talk about individual clinical situations all day long, but this really helps get it down into something simple. The first one, is there a failure or some type of impending failure of airway patency? Does this patient need to have their airway protected? And there's usually 1 or 2 things that we can assess to answer this question easily. anyone that's been doing this for a long time, especially 20, 25 years, for the probably the first 15 years you practiced, all you heard about airway and airway protection was gag reflex, gag reflex, gag reflex. And if you look into the literature, gag reflex is a very poor indicator of your ability to protect the airway. You can have a gag and aspirate. You can have no gag and protect the airway just fine. So it's probably one of the poor things to look at if you're trying to decide if someone can protect their airway. Big two things we look at, or the big question: can your patient control their secretions? Do they have an effective cough? Can they effectively swallow? The two things that we do subconsciously a bunch of times every day to manage our own secretions. But those are usually the two best tools that you have. A third tool you can add to that when you look at your GCS or your patient's mental status is the big saying out there: GCS 8 or less, intubate. If your GCS is decreasing, then your ability to cough and swallow are decreasing. So it kind of feeds into that same thought process. So when you're looking at airway protection, can your patient control their secretions? Yes or no? And that'll help you make that decision. If you look at a ventilation or oxygenation issue, just remember there, it's two entirely different processes. For a patient to effectively ventilate, it's rate and volume. For someone from an oxygenation standpoint, that's going to be a diffusion type of thing. So remember, two entirely different processes when you're approaching these. Anticipated clinical course to require intubation. The burn patient's a good example with an upper airway, maybe an inhalation injury. That patient's GCS may be okay, but if they're nares, their oral airway, you look inside the mouth, you see soot, that type of stuff for burns. You know that the picture you're seeing now is going to be completely different in 30 to 45 minutes or even an hour, when that airway will be tumultuous or maybe even impossible to get. A multi-trauma patient that's EMS has picked up, they've gotten access, they've gotten crystalloid or blood products in place. This patient's stable when they get to you, but you can look at multiple ortho injuries, pulmonary contusions, things like that. You know this patient's probably going to get worse before they get better. And this patient, you may elect to place an airway in that patient because of the multiple surgeries they're going to have or the treatment they may need. Sepsis the same way. Somebody getting 30, 40 kilo of IV fluid if they're in warm sepsis. Usually the number one organ that gets affected that quickly is going to be your lungs. Your lungs will hold a ton of water weight, but you may see issues with oxygenation ventilation from the AC membrane getting thicker just from the edema that's there. So we have to move that way as well. But just keep those three questions in place. No need to make things difficult and knock out tons of specific clinical scenarios. Can they protect their airway? Can they oxygenate and ventilate? Is this patient's presentation going to be something short-term or long-term to where you just need to intubate them up front and get everything done and be done with it? All right, next slides. Now we'll move pretty quickly. Assessing the airway or identifying the difficult airway. Most courses that do this now, they're going to break up the airway approach into 4 different paradigms. Difficult BVM, difficult laryngoscopy, difficult SGD, supraglottic, extraglottic, and then any difficulties you may have in doing a surgical crite. So each one of these, of course, has a mnemonic to go with it to kind of jog your memory and let you run through these things when you're doing a lot of them. But we're going to quickly look at each of these from an assessment piece, because even with everything we've talked about, these 3 slides here are going to be the ones that keep you out of trouble. You agree, John?
Yeah.
They're going to be the ones that either make you change your approach or maybe decide not to even do anything other than support oxygenation, ventilation, and get moving to somewhere that can provide help. All right, next slide, Keith. So if you look at difficult bag valve ventilation, again, Roman's the mnemonic. So if you look at the R is going to stand for radiation or restriction. Keith and John have already put some shadowing on that. For someone that gets radiation treatment, the airway is going to be affected. Structures you may identify may not be in the same place or be unrecognizable. They may be swollen. The surgical piece that they had maybe before they had radiation done may presents you with an entirely different functional airway than what was present prior. So you have to pay attention to that. When you look at restriction, this can be from obesity, could be from asthma itself. When you look at that, be someone that has reactive airway disease, not reactive airway disease, but somebody that has obstructive sleep apnea as well. You're going to have to utilize more pressure with your BVM to get that airway open and work through it. So when you look at the R, radiation restriction, kind of the first thing that pops into mind. O, kind of a catch-all, and I kind of foreshadowed it. Obesity, airway obstruction, sleep apnea. Obesity, kind of twofold. The big belly is going to push all your abdominal contents up against the diaphragm and then push the diaphragm up in the thoracic cavity. So that's going to predispose you to having to use more airway pressure to just simply get a breath in from a physics standpoint. That's going to predispose you to the patient maybe having an emesis event, which none of us get paid enough to get vomited on. So please avoid that at all costs. Then the excess weight on the chest as well is also going to doubly require you to have to use more pressure to get chest rise and fall. Obstructive sleep apnea, kind of the same way. You may have to use more pressure to get that airway to open if that's there. If you have an airway obstruction, it kind of depends on two things. Number one, where that obstruction is located, and the second thing, whether that obstruction may be fixed or a compressible. If it's a forearm body, if someone's maybe aspirated, there may not be much you can do to get around that obstruction to make things better. Someone may have some type of upper airway tumor that when you put CPAP or positive pressure on it, it compresses that tumor and you're able to get the airway open. Seen that happen a couple of times. So if you look at obstruction, what kind is it? Is it compressible? Is it fixed as far as getting around it? When you look at the M, mask seal, and then Malampati, two big things you're going to have that give you big issues with mask seal or trauma, blood secretions, and then beards. We often think people that have big faces are great from a mask seal standpoint, but they usually have beards too, and it usually negates it. Most airway managers, if you open their airway bag up, you'll see either towels or washcloths in there. From a trauma standpoint, first thing you're going to do, wipe the face off, get that stuff off when you get a good mask seal, just to get that done. Malampati, we're going to do a photo here in a couple of minutes to show you a picture of that, kind of how to gauge it. Age, the A, if you're greater than 55 years old, that is associated with the higher risk of BVM, usually from a loss of muscle tone and more soft tissue that may be present in the face and in the airway itself. They say greater than 55, but again, there's no real hard number on that. Just be aware that someone older, you may have more issue getting a good mask seal. The N stands for no teeth. If someone has dentures and they are secure, don't take them out. That's going to give you structure to get a good mask seal. And if you can get your mouth open enough that it's not going to affect your ability to visualize your vocal cords, you can still leave those dentures in. If they're floppy and loose and causing an airway obstruction, then they've got to come out, and then our job is got a little more difficult from getting a good mask seal when we intubate. So if you're looking at BVM, that Roman mnemonic, something you can run through really quick, that you pick out things that may cause you difficult from a basic standpoint. All right, next slide, Keith. Thank you.
Running low on time too, Joe.
Yep. The lemon mnemonic, the L is going to be look externally. E, evaluate 332. M is going to be Malampati as well. You can go to the next slide, Keith. Just a quick look at 332. This is airway geometry. The first three is looking at the patient's mouth opening. You want at least 3 fingers there. Anything less, you're going to have a hard time being able to get a blade in and visualize the airway and place your tube. The second 3, the bottom left-hand corner, that's measuring your thyromental distance, tip of your mandible back to your hyoid bone. And then the 2 is going to be from the hyoid bone to your thyroid cartilage. The second 3, this is measuring the size of your mouth cavity. You want at least 3 fingers so you're able to get the mouth open, get the tongue displaced, keep it displaced so you can see. We've all seen folks that maybe have no chin or maybe 1 finger's width. When you open that patient's mouth and you give them drugs, their tongue is going to be all up in your way, and you're not going to be able to see anything except tongue, and more tongue. and when you try to get that airway. The two is going to affect potentially what kind of blade you use. If you can only lie one finger in that space, you're probably going to have a more anterior type airway. If you can lie 3 or 4 fingers in there, someone that maybe has a chicken neck, you probably need to go to a Miller 3 or a Miller 4 blade to have that extra length to be able to get down there to see that. So simply looking at these 3 quick things from the outside can give you a lot of insight on your approach. You may change it front side or be ready for it if you see it. Next slide, Keith. Malampati, again, this is looking at the upper airway. Anyone that's had surgery done has seen this done before. Open your mouth, stick your tongue out. They're trying to identify upper airway structures. Next slide, Keith. So if you look at looking at intubation, the Cormac-Lahaney score, get your blade in, get your best view, will grade the airway. We like to see grade 1 and grade 2. Grade 3 and grades 4, with your best view, you can sometimes do Selleck pressure or maybe a Burt maneuver, backward, upward, rightward pressure, and this may improve these grade 3 and grade 4 views to allow you to place the airway effectively. These grade 3 and grade 4s, you may elect to do a intubation with bronchoscopy, or you may choose to use a bougie and make these improve and get better. Next slide, Keith. All right, talked about the obstruction obesity piece. That's pretty simple again. And again, neck mobility, that's going to affect your ability to open the airway. And if you're manipulating your blade and handle or your video device, this may affect that. C-collars are not a contraindication to intubation. You can take that anterior portion off. If you do, someone must hold manual C-spine the entire time you're looking. Video is usually better here than direct, in my experience. You have to manipulate less of the neck to move that way with it. Next slide, Keith. All right, putting in supraglottic or extraglottic airways, rods is your mnemonic. R is going to be restriction, so tight lungs, COPD, asthma, or ARDS. Your supraglottic airways are not definitive. They can withstand about 40 centimeters of water of airway pressure, and then they're going to start leaking. So at that point, you've got a compromised airway. Ventilation, oxygenation may be compromised. So take that into consideration. Again, obstruction, obesity, same thing. Nothing needs to be in the way when you place it. To do that, obesity is going to take higher pressures to do. Disrupted, distorted airways, big thing here. Somebody's anatomy is not where it needs to be. Maybe it's not midline. Maybe you've had an injury to the neck, a clothesline type injury. You've got a partially or fully transected airway. Things are not going to work well. That short thyromental distance, that set the first 3, is the mouth big enough to get a supraglottic in place? And the second 3, the second 3, when you're looking at the oral cavity, depending on which supraglottic device you use, they may take up a lot of space and may prevent you being able to get those in place effectively. Next slide. For surgical crite, the mnemonic is SMART. We're simply trying to identify landmarks. We're trying to be able to find the thyroid cartilage, and to be able to where our surgical site is to make that. So any previous surgeries that are there that may be present that we know about, any masses, any issues with access or anatomy that may be there, radiation we mentioned earlier, any tumors that may be there, inside or out. John's case was a perfect one. There was a tumor there that they probably could see externally, but they could see it from a radiology standpoint. And if they had to correct that patient, we probably had a hard time finding landmarks for it. So SMART's going to be your mnemonic you run through to assess your ability to have a successful surgical crite procedure done. Next slide. All right. Promise you I'd fly through them.
So we can go ahead and we can go through these two. I just want to emphasize, guys, that we have ways to correct type 1 respiratory failure and type 2 respiratory failure. Being number 1 is hypoxic or hypoxemic respiratory failure is type 1, and then of course your hypercarbic failure type 2. So we have BiPAPs that can treat that. We have heated high flows that can treat that. Taking somebody's airway and intubating a patient, again, is a high risk, low volume procedure. It's not something that we are all perfect at, but we do plenty of them. But there are things that we can do prior to taking an airway. I think it's important for you to recognize that when it is time to take that airway. If you failed BiPAP after a few hours, then you need to take an airway. If you failed heated high flow after max settings, you need to take an airway. So those are the things that you need to be thinking about. And that goes along with assessment and mitigation, right? So if you are assessing your patient based on them being on non-invasive for X amount of time, or a non-invasive respiratory support such as a heated high flow for X amount of time, and they're failing, then it's time to move on to your next intervention. Airway timeout, we talked about that. Taking a moment, identifying your patient, identifying what the problem is, and identifying that you're going to take this individual's airway checklist. I strongly recommend, you know what, when we fly, our pilots have a checklist that they go through in order to even lift the helicopter off the ground. A Cessna 172 has a trifold checklist before they even lift off the ground. Yet we don't have a checklist to go through when we put somebody on a ventilator, or when we put somebody or we intubate somebody. I strongly suggest getting yourself an airway checklist that you can keep in your airway bag, keep in your aircraft or in your ambulance, so you have that you can go through before you take a patient's airway. Drug assisted versus delayed sequence. I think Joe kind of covered that. When you would use ketamine on somebody versus when you would use something else. I can tell you that in some of the literature that I'm finding to do my lecture here in Orlando, finding a lot of patients that get propofol for induction, and it is almost all those patients become hypotensive. So again, just certain things that, whether they're in your protocol or in your algorithm, maybe think about what kind of effect that would have on your patient. Video laryngoscopy versus DVL. We can kind of advance the slides a little bit, Keith. I think there's a good paper here. It's called a device trial. It was led by the Department of Defense and Vanderbilt University. There are 17 centers around the country that did this, and many different cohorts. But I can tell you that DVL was inferior to VL when it came to visualizing airways. Now, that doesn't mean that video laryngoscopy is going to take the place of DVL and throw out all of your other supplies. That's not the case. But video laryngoscopy does offer you a better chance at first pass success. And first pass success has a lot to do with your patient not crashing and not coding. So the sooner you can get your patient intubated, the better. And I would please try and optimize it to first pass success. That's what we got. And what do we have for discussion or questions in our 5 minutes left?
While we're waiting on questions, the only thing I want to add that we haven't really talked about.
Yep.
We all train. We all want to do these procedures we're trained on. We all want to be good at them. And I'm just as guilty as anybody of thinking about things that way. But we'd be remiss if we didn't put this out there. Just because you can do something doesn't mean you should, you know? I'll let John and Keith chime in.
Man, if I had $1 for every time I've said that.
No kidding. I can absolutely tell you without any forethought or any second thought whatsoever, if I went back and looked at the top 5 airway cases that I've been in, probably 3 of them are going to be decisions that I chose not to do anything, to not intubate, to do something else. And I can go back and look at all 3 of those and realize just how much ugliness and how much badness would have happened if we had chose to, follow that checklist and do that procedure, because everything saying we should do it, except that little guy on your right shoulder saying, do you really want to do this?
Right.
You sure you want to do this? This is probably not the smartest thing for you to do.
Yeah, it's a matter of don't just do something, stand there.
Yeah, exactly.
And I had an old intensivist teach me that many years ago.
Hurry up. Don't just stand there and do nothing. Yeah, you're right.
Yeah. John, and you got about a minute about some overall take home message, wrap it up.
I think, just like you guys said, just because you have a hammer, not everything is a nail, right? I mean, identify these patients, make sure that you treat them appropriately. Hypoxemia is the #1 cause of peri-intubation arrest. I strongly suggest making sure that you use apneic oxygenation on your patient. Make sure that you hyperoxygenate appropriately. For patients that are hypotensive, I would strongly recommend having a levo drip handy, or at least some push dose pressors to get you through the intubation period to where you can hang a pressor. And again, identifying the correct patients for intubation. Not everybody deserves a tube. We still have instruments and we still have treatments that can mitigate hypoxemic respiratory failure and hypercarbic respiratory failure, I think that we should utilize those first before we do this.
So,
Couple of
so we have a
questions.
question up here. In a situation where EMS brings in a patient, they are actively coding with an LMA in place and ventilating well. The MD usually asks me to place an airway right away, but it would be much better to keep the LMA until you get return of spontaneous circulation is achieved.
That
What are your
is
thoughts on that?
standard ACLS as a
Yep.
part of the secondary survey is to intubate your patient.
Correct.
If you
There's
have,
nothing wrong with that.
yep, if you have
If
chest,
your LMA is functional, then you leave it.
yep, leave it.
And we have one more question. How does pre-oxygenation with NIV before intubation help in difficult intubations?
Well, if you have a difficult intubation and your patient's hypoxic, it's going to be really difficult because you're probably going to have a coding patient. So pre-oxygenation with NIV, when you start to induce your patient, you have a backup rate where your BiPAP can deliver your backup rate at your set pressures with 100% FiO2. And we are not good at bagging patients. You generally have to have 2 people in order to have effective BVM. So I would say that there's good literature that I'm going to be presenting at Congress that talks about using non-invasive positive pressure ventilation versus a BVM and the benefits that
There's a
Well
good
said.
body of it. There's a good body of evidence from pre-hospital and in emergency medicine too, looking at, in addition to using non-invasive, placing a medium flow cannula on your patient along with your BVM and a PEEP valve.
Yep.
Now, for those of us that know what's going on, when you're doing all those 3 things, you're pretty much doing NIV.
Yep.
Because you've got flow and you've got a resistance and you're giving some CPAP. But the benefit with having a medium flow cannula there, when you pull the mask off to do your procedure, you still have 15 liters flowing in there of passive oxygenation going on. That may buy you some time if it's a difficult case. Something to think about, keeping your back pocket.
Yep.
Well said, gentlemen. I want to thank everybody for joining today. I want to thank our experts that presented. As you see on this slide here, you can email me any questions or things that you want to talk to us about. You can go to our website and recommend topics for discussion in the future. We've decided that our next topic is going to be the use of lung ultrasound by RTs, et cetera. And so we'll talk in general about lung ultrasound. This panel discussion will be available on our YouTube channel soon after we conclude here and we can get that wrapped up. And so feel free to review that or send that out to whomever you might think would benefit. So with all that said, I appreciate everybody's participation and hope you guys have a great afternoon.
Thanks, everyone.